The Journal Club is July 3rd, 2013. We are 2019. Sorry about that. We are live with Journal Club from Neptune, New Jersey. So we appreciate everybody tuning in. I'm told to like us on Facebook during this event, and we're going to go through some of this stuff. It's July 1st is a new academic year, if you don't know. So we have 7 new fellows on top of the 2 that are currently here. So we have 9 EMS fellows, the largest program in the entire world, the largest physician response program in the entire world. So normally what we do, if you don't know, if you haven't joined us before, is we go through interesting cases, focusing on EMS cases, but since everybody's new, we might not have EMS cases to go through, so we'll go through some interesting medical points. And then we'll do our Journal Club articles. For those of us who follow us regularly, we do the same articles every single year for the first Journal Club. We always do Scott Weingart's article, so if he's watching, that's great, because we always say there's one article you should read that will make you 90% more than everybody else. It's Weingart's article, so we'll talk about that. And then we added this year the article that we really liked, which was on how to dose drugs properly based upon body weight, which was, we really liked. It was a review article, but we kind of liked it. All right, let's get started. So I have a couple of interesting things, because I work clinically July 1st. I was covering somebody's shift. So it's always interesting to work clinically July 1st. Does anybody have any interesting cases though? Because we'll take stuff from the ER too.
You know, on traumatic arrest, what should we be doing for these patients? And a lot of times, the discussion is had is that most medics and most even ER docs, when you see these patients in the trauma cessation bay, they go to giving epi, and doing chest compressions and giving bicarb and all these useless drugs to patients. And we've had a couple calls to our console, which I've QA'd, where we have patients being called in for traumatic arrest, and they've given epi, and they're asking for bicarb, and some of our docs are even giving it, which is surprising. And we QA'd one chart where we gave orders for needle decompression and TXA to a patient who's in a traumatic arrest, and they weren't able to give the TXA, but they were able to give the 3 epis and the bicarb, which is it's just crazy.
Yeah. So what's the point here? The point is, in medical cardiac arrest, poisons don't work. Right. Antiarrhythmics don't work in medical cardiac arrest. Right. Epi has 40 years of literature to say you have more ROSC but no better outcomes. And then you have more recent trials to say it really doesn't work, right? So this is not new. And certainly in trauma, the poisons really, really don't work, right? So if you're going to do anything in traumatic arrest, if you make the decision to do anything, and certainly if you get there and somebody has a blunt traumatic arrest with no pulse at scene, their chance of survival pretty much is 0, right? We have the ability to ultrasound people's hearts, but so do several EMS systems now around the world, right? Yeah. So that's not new, especially with a more portable Butterfly IQ machine and some other devices that we have. But I mean, if you're going to do something, decompress the chest. We're big believers that don't freaking listen for lung sounds, because you don't hear good lung sounds on the side of the road. And if you convince yourself you do hear good breath sounds, the patient's at traumatic arrest. Stop listening, right? Don't take out your stethoscope. Just decompress both sides of the chest, no questions asked for the average paramedic. If we're there, we're going to put 2 holes in both sides of the chest and put 2 fingers in the holes, and we're going to put 4x4s in the holes to keep them open. And that's our standard. So we won't decompress the chest either, right? We won't decompress the chest, but every ALS provider should be decompressing both sides of the chest, no questions asked. Right. I've seen this at hospitals post-mortem. I remember this one young kid who's a blunt traumatic arrest, and nobody decompressed the chest. We got a post-mortem x-ray, and he had a huge tension pneumothorax. Right? I mean, don't listen. If you're spending time listening for lung sounds in traumatic arrest, you're doing the wrong thing. It should be a no-brainer. A no-brainer. When I was a paramedic in the 80s, we decompressed both sides of the chest, and that was our standard protocol, right? I mean, doing like the airway, sure, you want to do the airway, decompress the chest first, right? But that if you want to give TXA, sure. You have no basic science behind giving TXA in blunt traumatic arrest. Right. But if you want to do it, sure. But giving silly drugs like epinephrine and antiarrhythmics have no basis in medical patients, let alone traumatic patients. Right. Everybody agree? I mean, this is pretty straightforward, right?
I mean, this is kind of like the issue that I've always had is, number one, so what should we be doing really for these patients? And I'm an advocate of saying that we really shouldn't be even doing chest compressions in these patients. The tank is completely empty. When we're doing chest compressions, what are we compressing? There's no blood in the ventricles. They're empty. So we're not perfusing the heart, we're not perfusing the body, and even if we're pumping the blood out, probably out of some bleeder, which they've kind of bled out from. So the question is that do we put our EMS crew in harm when they're already driving pretty fast, probably get to a trauma center, doing chest compressions on a patient whose pump is completely empty? I know that we always want to do something, but the question is it really something that's worthwhile?
Right.
Right? Now, the next question would be then is that what does this patient need? Honestly, like I've talked to medics on the phone when they call me, they say we have traumatic arrest. And I say, you know, at this point I would be doing bilateral decompression. If you get ROS, great. If not, then I'm okay with terminating resuscitative efforts. But ultimately, if it's a witness arrest, if you want to do something, you know, at this point it's just going to be diesel, getting them to a trauma center where they can possibly open the chest and see if they can resuscitate the patient. But we know that the likelihood of them surviving is going to be very low to begin with.
But now if you have blood traumatic arrest and does make it to a trauma center, you just take an ultrasound, look at the heart, the heart's not doing anything, just stop.
They're done, right.
Right? I mean, the idea of opening up everybody's chest is a blood traumatic arrest with a heart that's not doing anything doesn't save anybody.
Right.
And again, you want to make 2 holes in the chest with 2 fingers in a trauma center? Sure, why not? Right? It's not, I don't think unreasonable. It's not all that invasive, right? Like, well, you know, why not do it, right?
Yeah. I think we used to be very aggressive in our traumatic patients to putting in bilateral darts, and that was something that we didn't hesitate at all. But I don't know, for some reason in the last decade or so, there's just been a little bit more hesitancy in doing this procedure. And it's not something that's just innate to actually do it. But I mean, if you have a blunt or penetrating, you know, I mean, if you have penetrating traumatic arrest, sometimes you can still get the pneumotension pneumothorax. And you have a traumatic arrest, just put the darts in. This should be a no-brainer.
Even giving IV fluids is silly if we're not big believers in IV fluids, even if you have a pulse and hemorrhagic shock model,
Right.
let alone somebody in traumatic arrest, from whatever reason their traumatic arrest is.
Exactly. If you're filling the tank with saline now instead of blood, that's not
Right.
going to do anything either.
Right. And I'm not sure blood helps too many people who have a blunt traumatic arrest anyway, right? Maybe we would do it, but I don't know that's helping anybody.
Sure.
Penetrating maybe somebody. You got to give me a good reason that, you know, of where they're bleeding from or something. I like pelvic binders, but in a traumatic arrest, I don't know that pelvic binders doing anything. My guess is nobody's ever looked at this. Maybe somebody did a subgroup analysis of pelvic binders in traumatic arrest, and my guess is it doesn't help too many people. I like pelvic binders, although I wish they were a little cheaper, right? I mean, that's the argument, a nice teapot or some sort of other, or stem splinter or some other device versus sheath. I know a sheath costs less money. I know it's not great circumferential pressure, but you know, in a fee-for-service model, buying very expensive devices is challenging. For some reason, I've always felt that the paramedic textbooks don't do good justice to the idea of pelvic binders, right? It's just not in there as much as I would like it to be, right? How many patients do you see where you're suspecting bleeding in the pelvis and people don't come in with at least a sheath? I never quite understood this, but I don't think we do a good job teaching people about this, right? I know, I mean, what's your experience? Are you guys seeing people who have bleeding in their pelvis routinely coming with pelvic binders or sheaths?
No.
Like routinely?
It happens, but it's not routine. Honestly, the only time I've seen it is when somebody clearly has significant pelvic trauma, you know, like significant falls with unstable lower extremities. I've seen at that point a few times where paramedics have come in with the binder on. Placing them correctly is another thing that I think we have.
But have you guys ever tried to put a teapot on? Like, it takes a minute, right? I mean, this is not like a 30-second, it's not a 10-second device, right? What did you guys have when you were residents? Did you have teapots or did you have other devices?
Mostly teapot.
Teapots. And I forget, I used to know this. How much does a teapot cost? Anybody remember? It's not inexpensive. We used to carry teapots all the time. We used to have a bunch of teapots, but it was just challenging, you know, do we buy teapots? Do we buy blood? Do we buy this, right? And I know sheets aren't as good as them, but again, they're cheaper.
Has anybody looked at sheet versus teapot?
Yeah, I mean, I know, right. So I have some literature that says it's no difference. I have literature that says it's a big difference. I'm sure everybody out there is going to give like a different opinion. I mean, what you guys learn as residents is you probably learned that the commercial devices are better than sheets, right?
My guess. You can certainly crank them a lot harder.
Yeah.
Right, because we don't pull sheets hard enough, right? Yeah, I mean, I guess I don't know. My experience is it's not really in the paramedic textbook very well, right? I don't know. I don't think when I was a paramedic anybody even mentioned this to me, right?
had
all
a
right.
nice wide complex dysrhythmia that the medics were calling a STEMI, and one of the residents was looking at it on the console, and I said, yeah, a couple of it looks elevated, but it's pretty wide. I was like, just give calcium. And they're like, well, they're calling it a STEMI. I was like, I understand, just give calcium. And they call back and they're like, it's a normal sinus rhythm right now. And like, patient had no history of like.
Right. So people who follow us hear us say this ad nauseum. We're big believers in throwing. I don't think ACLS does this just either. Throwing calcium at people over the console. Right. If you have a new onset bradycardia of any type, I'm throwing calcium at you. Who cares? Maybe you're hyperkalemic. Maybe you're not. Most EMS providers don't have point of care testing. If there's a chance you're hyperkalemic, then just give it. Who cares? Right. Even if you don't give me good history, if you're a new onset bradycardia. I mean, how many people here, I mean, I'll step up to the plate and say I did it, put a transvenous pacer in, and we're getting ready to float a pacer wire when somebody, for a new onset bradycardia who is mildly hypertensive, and somebody says, the K is 8. And you go, all right, I guess maybe I shouldn't be doing this, right? And then you give calcium, and you fix a person transiently, right? So that just kind of, and until you do that once or twice, you realize, like, throwing calcium at a lot of people with new bradycardias is something we love to do. Right, so we love to do that over the radio. Calcium, throw calcium at them. You know, calcium chloride, when it's available, 10% is 100, 10% is 100 milligrams per ml. If they're 10 mLs at them, which is 1,000 milligrams, who cares? If you're wrong, who cares? If you're right, you'll save their life. What do you guys have, pet peeves, that you see done wrong consistently, and you just go, why do people not get this?
Patient lying flat.
Yes.
The patient
Right. So how do you position people when you intubate them? Well, we can quote lots of studies, but let's just summarize it. Sit them up while you're intubating them. Sit them up before you intubate. Sit them up while you're intubating, and sitting them up after you intubate. Right. So it's, you know, we still show that picture in that American Journal of Emergency Medicine article. I forget, it was done in some residency where they have a picture of a resident intubating with a guy sitting up. Right. You say the xiphoid process in that study. The more they set them up, the better visualization they had, the better success rate of intubation. Sit them up, sit them up, sit them up. You know, another thing is orthostatics, right? In our clinical pro book, you know, people are in love with orthostatics, and it doesn't really matter. I mean, Greg Henry, by the way, said this when I was a medical student, a famous guy in emergency medicine. He had this line that was brilliant. He said, if my resident comes over and says the patient's orthostatics are positive, I think about the patient, and if I can't figure out why they might be positive, I ignore my resident. Isn't that brilliant? Right. I remember an article in Mayo Clinic Proceedings that said 30% of people have positive orthostatics who are completely euvolemic. Right? So, I don't know, if your orthostatics are positive, I think, can I figure out a rate? Then there's the old argument, I'll stop on my tantrum here, of the patient's volume depleted. Right? The best way to figure out if somebody's volume depleted is because they have diarrhea, or they have a history of being volume depleted, or they're in hemorrhagic shock. Well, the patient's tachycardic, so their volume depleted. Well, that's not true. Their BUN is elevated, so their volume depleted. Well, that may or may not be true. Their creatinine's high, so they must be volume depleted. That may or may not be true. Their mouth is dry. Well, their mouth has been open for 20 years, right? The best way to figure out volume depletion is by a history that proves volume depletion, like diarrhea. You want to do Weingart's article first? How do you guys want to do this?
Yeah, let's start with Weingart.
However you guys want to do, if you want to do sections or whatever.
I figured we'll just start from the top and then we'll kind of just break it down and
Just summarize it and our experiences?
Yeah.
All right.
Awesome. Cool. So the title for that article is Pre-Oxygenation and Prevention of Desaturation During Emergency Airway Management. Coming out of Annals of Emergency Medicine 2012 by the critical care guru Weingart and the airway guru of Rich Levitan.
So an older article, right? By now, I remember when it came out, this is not new news, right? So when people aren't doing this, you go, you're only, what, 8 years behind the times.
Yeah. And it's a good review. I think it's a great article for you to be providing to your medical students, EMTs that are training to be paramedics, even junior faculty or faculty. I think it's always a good article to read out, to brush on. Basically, they were reviewing pre-oxygenation and peri-intubation techniques to minimize the risk of hypoxemia during emergency trachea intubation with adult patients. They introduced, if you see towards the end, kind of like a risk stratification approach based on the initial pulse ox level and how to respond to that. They also provided certain techniques that would help, such as positioning, pre-oxygenation, the role of denitrogenation, the use of positive pressure devices to increase mean airway pressure, passive apneic oxygenation during the trachea intubation efforts. We can kind of go through each question, talk among ourselves, and see what's new, what's different, how we each practice our own. So the first question was, what is the rationale for providing pre-oxygenation before tracheal intubation? And as we know, pre-oxygenation is basically to provide a safety buffer during your periods of hypoventilation and apnea. So when you're trying to pre-oxygenate them to a level so that when you are going for that first pass and are unsuccessful, you want to be able to have that safe place for you as far as safe apnea. And they define that as the time until a patient reaches a saturation level of 88 to 90 before you're allowed to provide a definitive airway. The technique obviously is different how in the operating room to how we practice in the ED or in the outpatient, in the pre-hospital world.
Or ICU, because there's fair literature on both sides of this coin, right? And the ICU study was not very supportive of this kind of stuff,
Right.
especially high flow nasal cannula, right?
Yeah. And so in the operating room, it's all kind of mostly elective. They're able to provide more of oxygenation, ventilation, etc. versus our patients are very sick and have a lot of comorbidities. Pre-oxygenation has 3 goals: to bring the patient's saturation close to 100% as much as possible, to denitrogenate the residual capacity of the lungs, so to provide as much oxygen in those lungs, and then to denitrogenate and maximally oxygenate the bloodstream. But the first 2 are basically what you're going for. What is the best source of high FiO2 for pre-oxygenation? Can you guys throw it out there? You ready to pre-oxygenate the patient? What do you put on?
High flow nasal cannula,
Yeah.
normal breather as well.
Right.
So why don't people get this more? That's what I always wonder. Why is I still go to conferences and people like look at me crazy when I'm talking about high flow nasal cannula? Yeah, I don't know. I mean, is everybody? I mean, so we did a thing where we have like hard stops for our charts. So if a paramedic doesn't put on high flow nasal cannula, it's a hard stop. They have to like explain why. I don't know. Are you guys seeing people? Everybody brought in with high flow nasal cannula where appropriate?
No, not
So
all the time.
why hasn't the message disseminated out there?
I even see like a lot of respiratory therapists or something when I put a nasal cannula underneath a mask or something. They pull off
Right.
the nasal cannula. No, that needs to
Right.
stay. We're kind of creating a peak now.
Right, it's kind of weird. Like, why don't people get the message? Like, I get it. There are some studies on both sides of the coin, but again, our patients are different from ICU patients. When they code suddenly, I don't know that they need high flow nasal cannula, right? I get that. But our patients who are more hypoxic, a little slower, they benefit from it, right? And there's several studies which show better outcomes. I don't know. I don't know why people don't get this.
Just to clarify the terminology, when you say high flow nasal cannula, you're referring to a standard nasal cannula at higher
Yeah.
flow rates, or are you referring to the high flow machines that can deliver 50, 60 liters a minute?
I think it's a great question because we use the slang term high flow nasal cannula to mean stuff that really isn't high flow nasal cannula. So that's the outstanding point. And now there are commercial devices actually been around a long time, but now there's even a few more commercial devices available to do true high flow nasal cannula. And if you look at, I mean, the PZU at Northwell has been doing high flow nasal cannula for kids with like RSV bronchiolitis for forever, for years, right? So that kind of makes sense to me. So we have picked up this term high flow nasal cannula. It's not truly high flow nasal cannula, but this high flow nasal cannula in the NICU has been around for decades. This is not like a new concept. This is just, I think, somewhat new to us in the emergency department. So we are using it a little incorrectly. We're using it to really be like 15 liters per minute because we typically don't have, or at least our history is, we don't have the ability to give higher than that outside the hospital.
They go on to mention the face mask with an oxygen reservoir is actually a non-rebreather, even though we kind of say non-rebreathers and we have a one-way
Partial
valve.
non-rebreather, yeah.
Exactly. True non-rebreathers set at 15 liters per minute provide approximately 90% FiO2. So that would be more than in pre-hospital work. Standard non-rebreathers at 15 deliver 60 to 70% FiO2. Obviously, when we crank it all up in ED, we're able to go to 90% by increasing the flow rate to 30 to 60 liters per minute. When you have a BVM and it's just, which which I've seen many times, you kind of switch off the face mask and you put the BVM and you're just kind of hovering around there, not providing any ventilation. You're only providing them ambient FiO2, 21%. So something to consider. For what period of time should the patient receive pre-oxygenation?
So something gets added there. So I kind of exaggerate a little bit, and I call the BVM, the BOD, the bag of death, because I think you have to send a strong message out. And I say the most dangerous device we have in the ICU, the ER, and pre-hospital is a bag of death. With all the drugs we have, we harm more people by using the bag of death wrong, and we bag like crazy people, right? And this is like not a good thing we've picked up on. And you know, although I am exaggerating a little bit, I think people get the message. And I kind of say, listen, we're bagging too much, we're bagging too aggressively, we've done the wrong thing for years, stop it. You know, I basically just say if you're breathing like 6 times a minute and your stats roughly about 90 to 93, you don't need to be bagged, right? You need passive oxygenation, you need denitrogenation, right?
How long are you pre-oxygenating for? 3 minutes. 3 minutes, yeah. They should actually be receiving oxygen until they denitrogenate in order to receive at least a end tidal oxygen level greater than 90%. But obviously, you don't record end tidal in the ED compared to like some of the operating room anesthesiologists could. So usually it's acceptable 3 minutes worth of end tidal volume breathing where the patient's breathing on their own with that face mask. If you have a cooperative patient, you can ask them to take 8 vital capacity breaths. So at maximal exhalation followed by maximum inhalation, and that usually reduces your time to 60 seconds if need be. Can you increase mean airway pressure, and does that augment pre-oxygenation? And what are you using? Yeah, with the use of, obviously we know non-invasive positive pressure ventilation. And you use this when you are not reaching that 93 to 95% oxygenation or pulse ox. And that's when they don't, when you're putting on the face mask and they don't receive, they don't get to that level, is because they're shunting. They have some shunting physiology and you need to be able to open up the alveoli and provide more of an oxygenation pattern. In which position should the patient receive pre-oxygenation?
Sitting.
Head elevation position whenever possible, and when can't we sit them up? When they're immobilized for a possible spinal injury. And so what can we do in that sense?
Tilt the head,
Right.
reverse syndrome.
Reverse trim position. How long does it take for the patient to desaturate after pre-oxygenation? Yeah, definitely. Just some points here. When breathing room air, you receive, you have 450 milliliters of oxygen present in the lungs, and this increases to 3,000 milliliters when the patient is on 100% oxygen. When you're breathing room air, total oxygen reservoir in your lungs is approximately 1 to 1.5 liters. And when you're optimally pre-oxygenated, you have 3.5 to 4.0 liters. So some numbers to throw at you. You're consuming oxygen during the apnea period at approximately 250 milliliters per minute, so 3 mmLs per kg in healthy patients. Duration of safe apnea with on-room air is approximately 1 minute. If you provide them with sufficient oxygenation, it's approximately 8 minutes when you're on high FiO2. And then obviously, you know, in sick patients with poor cardiac output, when you depend on the pulse ox, how much does that delay by usually? It's like 30 to 60 seconds. So when you're already saying like, okay, now we're at 93, okay, you should think about bagging or anything like that.
It's another pet peeve. It's the pulse ox lag, right? Just relax. Just stand here. Things are going well for us. All I know is the patient's not becoming bradycardic. I know you have a sat that's a 60, but there's no waveform, or the blood pressure cuff is inflating. Take a deep breath. Things are going in the right direction, right? Just give it a minute. Yeah.
And these patients, obviously, in critical care patients, as fast as 23 seconds, they can start crashing down. Can apnea oxygenation extend the duration of safe apnea? Yes, definitely. And you can do that actually by using a nasal cannula set at 15 milliliters per minute. That's where it comes into play. When and how should we provide manual ventilation during the apneic period?
Only periods of desaturation after that.
can't reach that 93 to 95% oxygenation. Anything else? If I tell you that the PaCO2 increases 8 to 16 during the first minute of apnea, and then approximately 3 per minute afterwards, what type of patients am I talking about? So when you're thinking about patients that with like severe salicylic acid toxicity, or any of those patients that are hypoxemic, obviously. What position and maneuver should the patient receive during the apneic period? You kind of have articles out there. You can head elevation, chin lift, jaw thrust. When you're trying to provide them oxygen, you can. External auditory meatus should be at the same horizontal plane as external notch. Those kind of positioning. And then, does the choice of paralytic agent affect pre-oxygenation? They mentioned in the article, in patients with high risk of desaturation, rock may provide a longer duration of safe apnea. That's
Yeah, when dosed correctly, that's true. I read
when
that
dosed
paper.
correctly.
Right. This is the old Cochrane, Cochrane's review this with sucks versus rock. Actually, Cochrane review, sucks wins, but sucks wins because we're not dosing things correctly. And if we dose, if we dose rock at least, 1.2 mg per kg, rock wins, right? I actually say 1.5 mg per kg because it's easier, I think, in a moment of crisis to do mathematics for 1.5 rather than 1.2. But I know rock wins when we dose it right. When we dose it wrong, like 0.6 per kilo, sucks will win, right? And it will work just as, both drugs will work just as quickly. And the safe apneic period is different.
That's basically the summary, and I think the take home would be figure 3 and table 2 of that article, which is just saying, you have a patient, they're at a low, high risk, or they're hypoxemic, depending on their pulse ox reading. You start them on a non-rebreather. If they're low risk or high risk, and then when they're hypoxemic already, you consider using the CPAP or the BVM with PEEP. And then once you have the onset of muscle relaxation, you are going to continue them. If they're high risk, just bagging them. Obviously, you're bagging them low ventilation, low flow rate, and low number of respiratory rates per minute, the 6 to 8. And then once they're all of them, whether they're low risk, high risk, or hypoxemic, should carry the nasal cannula at 15 liters per minute.
So, the question is, this is all commonplace to us. It's just where we're starting. Why hasn't this really disseminated to the masses very well, right? And it's, it's not paramedics or EMTs, it's the doctors, right? I don't know, it was 2012, it was a while ago. So why do we still see things that aren't really done this way? That's the harder question to answer, right? Because it's not us, it's the masses of treating patients.
I think in our shop where I trained, we did this to every patient. We were like skiing off the jaw for jaw thrust. We had nasal cannula at 15 liters, a non-rebreather mask or a BVM to denitrogenate or pre-oxygenate. You really want to get that washout. You got to increase the oxygen, concentration at the alveoli space, so you get diffusion across into the bloodstream. Really, so I think that it was originally shown on a closed circuit in anesthesiology a long time ago, and now, being brought forward to the forefront again. But I think we do a good job of this in the shop where I was, but I don't know if it really made its way upstairs into the patients. I saw it intubated, in other places in the hospital. So.
Maybe it's just because if you trained a while ago, you didn't do this, and then you periodically just go to an update, and you have to attend certain classes. And if you don't attend a class on airway or oxygenation, you may not know any of this, and you just may continue what you're doing because nobody tells you anything. I think sometimes maybe you work in a shop where you have some younger docs who are well trained who come in and start doing this, and people start paying attention to it. Right?
That's true.
This is what we hear all the time, right? We've heard this for years. Well, we never did double sequence defibrillation in our ER until the paramedics started doing it. We never did push dose nitro until the paramedics doing it. We had a nurse in one hospital who who said to one of our paramedics, "You'll never believe what this EMT did. They came in here and they put oxygen on a nasal cannula on somebody at 15 liters per minute. How crazy is that?" And I thought, we've been doing this for years. Why is this nurse just never pay attention to this? Right? We've never seen it. Even push dose nitros. A couple people said to me, "You guys are just starting to push dose nitro?" No, we've been doing it for years. We've been giving reports for years. When we said we were bolusing nitro, what do you think we meant? And we thought that was just like a nitro drip. Like, no, we've been bolusing it. And this is the problem, we try and disseminate this information, but people have to bring it back to other people, and it just takes a while to disseminate current information. But 2012 is too long ago, right? I assume all this stuff is things you guys did all throughout training, right? This is not new. But we're the exception. We're not the masses. The masses have no residents. The masses are community hospitals, and it's very challenging to get this information. And I can tell you, by working sometimes at community hospitals, there just aren't enough academic discussions in community hospitals. Discussions focus on a lot of other things, but a monthly meeting where the doc will sit around and discuss like interesting cases or updates and stuff just doesn't happen that much. So you rely on conferences, but people have to go to lectures at conferences, right? But again, it's up to us to go into community hospitals and like change them and watch people model the right behavior for other people. But we go in and like the nurses like are the ones who carry this because they go, well, that other doctor did this. Don't you want a nice nasal cannula, or don't you want this? I don't know. Any other thoughts about this?
I think respiratory therapy is also another key. They've been slow at one of the places that I used to be to come on board with this, and so they would be present in a lot of intubations, and they could potentially be another source of a group that could really carry the flag.
Yeah, so it's an opportunity to say, hey, let me send you a couple of articles.
Yep.
Like, hey, I know you're a really smart person. I mean, there are many respiratory therapists who know a lot more stuff about the vent than I do, right? Because that's what they do for a living. But they just didn't read the papers about high flow nasal cannula or PEEP valves, right? So here, let me send you a couple of papers because there's a whole lots of stuff. And then I send them a paper from 2012, right? I go, there's even more literature than this. The drug article with the increased body mass. Who wants to talk about this a little bit? I mean, I think this article was from this past year, and yeah, and we had a lot of people who wrote to say, I think I've been dosing drugs wrong for years, right? I don't know, like I definitely learned stuff from this article the first time I read it. So I read
Well,
it.
it's more that you look at it and you think back to when you were trying to intubate or trying to medicate this patient, and then suddenly you realize that you were underdosing them, and that's why you had this adverse event.
Or overdosing them, or
and why isn't it working? Is because I wasn't given enough. Right.
I mean, you guys have to agree with me. If you gave a quiz on these drugs based on this article to your colleagues, how would they do? like, did you know this stuff? Like, when you read this article, I mean, come on, let's be honest. Did you really know everything in this article? Right? Isn't this kind of a little bit surprising? And did you stop with any of these drugs and say, I think I've been doing the wrong thing?
Oh, 100%.
Right?
Yeah.
I really like this article. Who wants to start with
Talk
this?
about it.
Dustin?
Yeah, so this is the crashing obese patient, Western Journal of Emergency Medicine in March of this year. So it's kind of a narrative. It's not really research, but it talks about what emergency physicians are kind of faced with an enlarging kind of body mass population. So there's a lot of things to think about, both anatomically and physiologically for these patients. This paper really focuses on what it comes in to be like for RSI, rapid sequence intubation, mechanical ventilation, and the pharmacokinetics with medications that are kind of selective for this paper here. So really there's a lot of anatomical differences in these obese populations. You get a lot of adipose tissue both in the chest and the neck, both anterior and posterior. So all this cervical adipose tissue narrows the airway opening when you do finally get a view. These are very difficult patients to intubate at times. So every patient that comes in that's obese has to be thought right away that this is going to be a difficult intubation. So it needs to be set up as such each time. So the adipose tissue, even around the back, limits your ability to kind of extend the neck to get that kind of view of the cords when it's time to take one of these patient's airways. Not to mention the adipose tissue that sits on the chest. So that adds a lot of weight, so you're decreasing the compliance of the lung. There's a lot of physiological changes that go along with the lung too. They have a decreased functional residual capacity, a decreased compliance in the lung itself. The weight when these patients lay back, you really decrease the total lung volume with the TLC in these patients. So pre-oxygenating these patients, is you have to pre-oxygenate these patients. I've had the older docs where I work say, man, we really don't see any peri-intubation arrests anymore. Where back in the day it was like we were intubating, and there was always, you know,
Right,
an
right.
arrest
When
or
I was a
something.
medic,
That was-
everybody threw up.
I've only seen one peri-intubation arrest, you know, in my whole time through residency, because
That's so
we do
freaking
these
weird,
things. Yeah.
right? I mean, there's a famous paper several years ago which said, you know, the average number of people, the peri-intubation arrest rate is 1 out of 5. If you're hypotensive, it was 50%, right? And we don't see that much anymore, right? It's just bizarre. Or people vomiting, you know, like everybody I mean used to vomit because I used to bag like a crazy person, because that's what somebody told me to do. They used to tell me, you know, that RSI was rapid sequence intubation. It's really slow intubation, right? I mean, and I used to beg like a crazy person. Everybody used to throw up on me, and then I started to realize, God, I was opening up the lower esophageal sphincter. I was causing gastric distension. Who was the crazy person who taught me this, right? And I thought, what have I been doing, you know? And now, like, you know, now when somebody comes in and they have a big abdomen, you know, and they're throwing up, you go, somebody just bagged too aggressively, right? The right person just didn't get to this patient soon enough, right? And it's a famous saying, he's desatting bag faster, right? I keep it simple. If anybody ever tells you that he's desatting bag faster, just walk out of the room, right? It's just not true, right? All right, keep going.
So so we don't see those intubation arrests really anymore, because we know that hypotension, hypoxia, and acidosis are kind of the 3 big causes. So, you know, decreasing you know, the patients that we have that are hypoxic in the peri-intubation period is you know, paramount, just like we got done discussing with Weingart and Levitin's article. So the best way to really kind of pre-oxygenate these people is with a non-invasive positive pressure ventilation. CPAP is the big one with the research behind it. You know, bi-level you can use as well, but really putting these patients on CPAP to, you know, decrease the atelectasis, to keep the alveoli open, and to really pre-oxygenate effectively. Still on your CPAP mask, I put a nasal cannula on 15 liters, so when the CPAP mask comes off, you have some passive oxygen, you know, flowing down, you know, the back of the pharynx and into the lungs there itself. So when it talks about intubating these patients, it's all about positioning. We talked about it earlier in the other paper as well. But we really want to ramp these patients up. You know, they have a huge amount of adipose tissue, so it kind of throws off the normal kind of dynamics of even a supine patient. You know, it's almost kind of like the opposite of really intubating a child, where sometimes you put something behind the back of the head. This, you really want to ramp some stuff up under the shoulders, even down into the middle of the back, to kind of raise everything up so you can get the external acoustic meatus right at that sternal notch. And even getting them up in a semi-recumbent position, you know, at least 25 degrees, I would say, even more than that if possible. That way you get a little bit of gravity on your side to really draw out the lungs and expand everything, so you can pre-oxygenate the best you can before intubating these patients. So getting a view in some of these patients is very tough, so you have to be set up for a difficult airway. So set up with your surgical equipment ready to go. A lot of these patients, you're not even going to be able to feel the landmarks of where you make a cut. So you have to know in your mind that you're going to have to maybe dissect down a little bit, really, to feel the landmarks before you're able even to get in through the membrane there. So these patients have VQ mismatches with everything going on, and even where did I have them? I wrote down something here. So the obese patients, the work of breathing is a lot harder. So they have more, they produce more CO2 than non-obese patients. So they develop this kind of rapid, shallow breathing. So when you are providing ventilation to these patients, you have to keep that in mind. You know, you got to for the first minute or two. Afterwards, you may want to give them a little bit more breaths once the tube's in, the airway's secure. So that's patient positioning stuff. And then the big thing is the pharmacokinetics. This is really the dosing. So you really have to think here. So a lot of drugs are hydrophilic or lipophilic, and this is where the volume and distribution comes into play. So drugs that are lipophilic have a massive volume of distribution. They go into the kind of the adipose tissue there. Drugs that are hydrophilic have a low volume of distribution. So here it talks about kind of different medications that can go through. And sorry, I didn't memorize all these, because this was the cool part of the article that I really had never even thought of, you know, going through, you know, my 3 years of residency at all. So it breaks it down into like cardiovascular meds, sedative meds, antimicrobial medications, and then anticoagulations. So cardiovascularly, it talks about some big ones: beta blockers, calcium channel blockers, DIG, lidocaine, and procainamide. So the beta blockers, DIG, and procainamide are relatively hydrophilic. So these have a kind of a low volume of distribution. So they're dosed on ideal body weight. So if you use the patient's body weight that's in the computer or system where you're at, or you're making a guess, judged off their body happiness, you're grossly kind of overdosing these medications.
I'll admit this. I never dosed procainamide like that. When I worked in the ER, I never did that. I used to
Ideal
give
body weight or where?
ideal body weight procainamide. I used to give like 750 or 1 gram over 20 or 30 minutes. I never did it based upon ideal body weight.
Yeah, no, I
I mean, have you guys? Who's going to step up to the plate and be honest? Do you guys use ideal body weight for procainamide?
honestly, when I look up the dosing from time to time, these drugs aren't ever specified to ideal body weight or anything like that. It's just kind of mgs per kg.
Yeah.
But calcium channel blockers, they're lipophilic, so it should be dosed on the total body weight. I definitely, that part, I'm doing. That part I'm definitely doing. I'm looking at the patient, but I'm doing that with the rest of the drugs as well. Beta blockers.
So is the reason that we hear diltiazem doesn't work in some people because we're underdosing it with people overweight?
I think so. There's been times where I've calculated a dose of cardizem, and it's been rather high, and I don't know if it's from something that was instilled in me early on in my time, but I always felt like the number 25 was a number to stop at.
That's what's in the book, right?
Yeah, so.
You're right, 0.25 per kilo, and then repeat 0.35 per kilo.
Yeah,
I
and
say,
then-
give me a break. You made that up. You put it in a book, and because you put it in a book, it's like gospel, right?
Yeah.
But it's not true.
But really, when I tell somebody, if over 25 milligrams of cardizem push, people kind of look at you. So I've always just stopped at that kind of 25 as the next, just arbitrarily.
Right,
so,
right.
A lot of it, like, unfortunately, with all these obese patients and their dosing, you are 100% guaranteed you're going to get a call from pharmacy.
That's
And
true.
then,
It's very
so you're
true.
going to get a call from pharmacy, and then the nurse is going to be like, "Are you sure?" And then the nurses, I've had this happen where it's been the person's home insulin, high dose, and they're like, "I don't feel comfortable giving this medication. It's too
Right.
high."
So then the secret I've learned for that is you find somebody brilliant who's a pharmacist who's on your side at every hospital,
Mhm.
and you let them have the pharmacy battles.
Mhm.
So we have somebody who's a community, Andrew. So we have this guy, Andrew, who's the ER pharmacist at community. He's come to journal clubs. He's read our book. He hands people the book. He goes up to doctors saying, look, they're saying this in this article. I think you're not doing the right thing. And he does the right. Oh, so you right. So you can get to speak about this more than I can. And then he has like pharmacy residents and stuff, which I think rotate with us. And right, so he battles it, right? So
Yeah, but it's sometimes it's just a long and tough road. He's still, of course, because he's a pharmacist, he always is very good about kind of approaching it in the right way. And he's like, are you sure you don't want to give TXA to this bleeding tunnel patient? Like, this is the dose. In fact, I already pre-made it and it's ready to go. That's his MO.
right. So then so when somebody says, well, I'm the pharmacist, he can go, well, I'm the pharmacist too, right? So that's what you need, like in every hospital, somebody on your side in every area to say, yeah, I'll take care of this for you. Don't worry. Yeah, we're not doing a good job here.
Where I trained, I was lucky enough to have probably one of the most brilliant ED trained pharmacists you could ever hope for, and she was available day and night. And at any point, if you had any sort of question about, hey, I've got this unusual, kind of scenario, or hey, this is not really driving right, or I'm getting a lot of kickback from the pharmacy department, she was a wizard about getting a hold of them, and she'd take care of everything. The rubber met the road when it came to what she said.
Right.
And incidentally, she was Andrew's student.
Yes.
Oh, that's great. Oh, that's great.
Yeah,
Great.
Gabby up at Hackensack.
Learn the good habits.
Yeah, that's great. All right, keep going.
All right, so the next set of medications it talks about is the sedative medications. So this part was very interesting to me as well. So it says that these sedative medications are very lipophilic medications, but they have very prolonged half-lives in obese patients because they're uptaked by this adipose tissue. So really, when you're dosing these medications, it should all be on ideal body weight for the initial dose, and then subsequent dose should be based on your kind of clinical correlation with how the patients are responding. especially in the setting of benzodiazepines in these obese patients. You know, with me, with these sedative medications, I've always just done total, kind of body weight, whatever was in the computer or whatever, in kind of a quick scenario crash patient, whatever we were collectively guesstimating the patient's weight to be.
I always think dosing of benzos is such a silly thing, 0.1 per kilo or something. I mean, it's such a titratable drug. You give an amount, you don't know quite what's going to happen to you give another amount. Some people might give 10 IM of Versed, some people give 5, some people give 3. It depends which article you read, what the right dose is. You give some, not too much, and then you give some more if that's the route you're going in, right? Hopefully it's not the route you're going in for RSI, but if you're giving it for some other, if you're giving it for like a seizure, you give some and then you give some more, right?
I think the hardest thing with that is waiting long enough.
Yes, because then you give more and more and more. Then you so it's sort of like the old days when you would do like a shoulder reduction by just giving a benzo, and then you give more and more and more. And when it finally kicked in and you could do it, then the patient would be out for like 3 hours, and you go, why not just give like ketamine or etomidate or propofol or something? Right?
The next set of medications is the antimicrobials. So this really says that a lot of obese patients are being underdosed, especially in the setting. Talks about in vancomycin for every 10 kilograms increase in body weight. So really should use the total body weight when using antimicrobials. And for penicillin, cephalosporins, and the carbapenems, should be using the upper limit of the maximum for all these. Aminoglycosides is the one caveat to that, where it really should be ideal body weight. And if you really need an aminoglycoside at a large dose, it looks like it's probably better to get pharmacy kind of involved to help you with a little bit of dosing, so you can really get coverage on these people. Because if you're underdosing somebody, in the setting of sepsis that's very obese, you're really not providing the care they need right away. You're kind of just
right. So I remember always learning like Rocephin was like 1 gram if you're going to give it for cellulitis. And then I got to one hospital, and I saw this one ID guy always give 2 grams for cellulitis. So I said to him, I'm just curious, I've never seen anybody give 2 grams for cellulitis anymore. And he sits me down, he goes, more. And I'm like, all right, he's going to say something brilliant. Because some of us in ID are overdosers, some are underdosers. I'm an overdoser. And I'm like, really? And he goes, yeah. He goes, if I see somebody and they have cellulitis and it's straightforward, I'll give them 2 grams of Rocephin, because if I'm going to discharge them, right, then at least they're covered for 24 hours, right, if they don't get to the pharmacy. That's really interesting. So I started doing that for all my patients with like cellulitis. I would give them 2 grams of Rocephin if I was going to send them home. Then I got to my next hospital, and then it was a different system, and I gave 2 grams of Rocephin. And I got like 10 calls from pharmacy going, this patient has meningitis? And I go, no, this is what I do. And they go, well, we don't do that here, right? And I'm like, it's kind of interesting, It's like, he goes, it's totally wrong in this hospital, but maybe it's right in your last hospital.
Oh yeah, I've been there. I've put in an order for 2 grams of Subtraxone for a patient under recommendation of the admitting doc, and then the attending comes running up. Oh, are we worried about meningitis? Why? Just treat. So anticoagulation medications, the last medications they talk about, and this one I've been involved in myself. So especially with like Lovenox. So the recommended dosing for Lovenox is 1 milligram per kilogram. And in these obese patients, a lot of people are stopping short and kind of underdosing these. So I've actually had to call from pharmacy, freaking out like, whoa, that's tons of Lovenox. Is this how we got to give it? So they look that up and then kind of call back and say, okay, it looks like let's just do this dosing of Lovenox. And I think a lot of times I've been in the bottle with pharmacy, they always settle on a number between like 100 and 150 milligrams.
Right, as a max dose.
Safe.
And I've asked that question to so many people, what's the max dose? But I think it's a silly question. I mean, with Lovenox, I guess you can check factor 10A levels, but we don't know in the science what a real 10A level should be. It should be between 1 or 2, we just don't know. So how do you really know if they're therapeutic or not? And the answer is because it usually works. But I don't know, why can't we give 200 of Lovenox? Is there a reason?
I don't know.
Has there been a study to show you have worse outcomes if you give 200 Lovenox and there's more bleeding and more people have bad outcomes?
I don't think so. My conversations with pharmacy are like, I can't find a maximum dose, but I'm comfortable giving this dose here.
Right.
So.
What's the highest dose of Lovenox you guys have ever given? Anybody ever given 200 Lovenox?
I've given 200.
You given 200?
Yeah, just.
Are you gonna go to jail or anything?
The patient didn't bleed out.
Pharmacy released it. Yeah.
Right.
Yep.
And then the only other thing it talks about is heparin, but you have to worry about volume with heparin in some patients, especially at large doses. But that's really tough. But this part of the paper was very interesting. Something I've never thought about personally. It was never really brought up during my training times, anything like this. But the rest of the paper, the setting up for difficult airway, the positioning of the patient, the pre-oxygenation, what to think about when intubating this patient is all, a very good narrative, a very good reminder. I think, we were doing this a lot where I trained for residency, but more and more people that we see are kind of meeting this criteria and falling into this. So it's becoming like a routine way for us to handle these crashing patients.
Yeah, the other argument I hear people say is it's not FDA approved. You can't do it. It's not. But if you look at it, 75. But one of the greatest lines I ever heard was 75% of what we do in the pre-hospital setting is not FDA approved, right? So it doesn't really apply to us so much. Even in the ER, you don't know what you're doing if it's FDA approved. You just go, well, this is what I know to do, right?
Very true.
Anything else with this? So hopefully you guys learned something. I mean, I learned every time I read this article, I learned something else. I've learned that maybe I should have been paying more attention to pharmacology. I'm not sure. So, but I learned how to better dose the drugs. Any other comments about this? No. All right. Nomination? No. And that was the only other article, right? All right, everybody. Thanks for joining us. 2 websites: www.emsfellowship.com and www.md1program.org. All of these journal clubs are on the fellowship website, and more information about our physician response program is on the MD1 website. Thanks for joining us.
Hey everybody, Ed Bowder and Dan Schwester from The Overrun. We are here in lovely Neptune, New Jersey. We just got out of the journal club with the MD1 organization, organization we've been working with here in New Jersey. Their journal club, it's the first of their academic year because the first day of the new EMS fellows are around. So they went over a couple articles and talked about some new things. So first article they talked about, what were some big takeaways?
Well, the first article they did was a classic. It's from 2012. It's the Levitan-Weingart apneic oxygenation article. This is what brought in the idea of the high-flow nasal cannula. I don't care who you are, you're paramedic, EMT, respiratory therapist, physician, nurse, you should read this article, you should know what it's about. If you're an EMT student, you should be reading this article.
So there's not a lot of articles that are really, truly practice changing, and this article really is.
Oh,
Weingart and
absolutely.
Levitan talked about apneic oxygenation, how you can actually put someone on a high-flow nasal cannula that's at 15 liters, and you can actually keep them oxygenated perfectly fine. It changed how things work, and still 7 years after the paper came out, we're still debating for some reason how this apneic oxygenation works.
We're still having fights over this.
Yeah, and we do it every year. This is the first paper that the EMS Fellowship works with, and they always discuss that you can use apneic oxygenation perfectly fine, nasal cannula to denitrogenate a patient, and it works perfectly fine. Second paper, go ahead.
And it gives your patient a very good margin of safety so that you're not hurting these patients on intubation. And let's say you don't get it first pass intubation, you got a chance, and you got that patient who can stay physiologically appropriate for a longer period of time. So it's good for the patients, good for you.
The important thing out of this is that this is not new data anymore. This is stuff that's been out for a very long time. People that weren't in medical school before this paper came out are now out in fellowship. It is not new data.
No, it's not.
Everyone should know about this. Okay. Second big paper they talked about was how drug metabolism is affected by body mass index. A lot of the drugs that we give, we tend to do ideal body weight. And if you have someone who's obese or very obese, and let's face it, we're in America, a lot of us are obese.
A significant percentage of the population is obese by body mass index.
So when you're looking at that, it changes how the drug metabolizes in patients. It depends if they're lipophilic, if the drug is lipophobic. So the actual dose that you have to give might change depending on the patient's body habitus. And one of the problems that we have in hospitals is sometimes it's dependent on the pharmacy and not so much the physician or how the patient might respond to the medication. Super interesting discussion. I don't know that it's going to be practice changing for us pre-hospitally, but it's certainly something that we should consider when we're thinking about giving drugs like Cardizem or even things like ketamine or fentanyl.
Right, and especially when you hear one of your doctors say, hey, give them this instead of this. Remember, protocol is protocol, but your physicians do have that latitude, and that's okay. They do read this stuff. They may be a little bit more on pharmacology than we are, and we don't get a lot of pharmacology in our training. So trust them a little bit.
And a principal difference in physician education versus paramedic education, paramedics tend to get taught what to do. Physicians get taught to think about what they do.
Yeah, that's a good point.
And so this is a big thing for that. So those are the 2 big papers they went over today. They went over a whole bunch of other stuff. It's an hour and a half worth of material that I think was really good. Big stuff coming out from the EMS1 or the MD1 program, EMS fellowship, and the overrun. So we got a lot of good stuff coming up in the next year.
Yeah, if you're interested, again, this is going to be on our site, but check out the MD1 program at md1program.org. Check out the EMS fellowship at emsfellowship.com. And, you know, it's just a great program. We have one of the biggest physician response systems in in the world here in New Jersey, and it's really a top shelf program.
It's good stuff.
All right, take care.